When we're talking about an ST elevation myocardial infarction or a STEMI, Q waves can show up, and they can signify either an acute MI or alternatively a historical MI. In the past, Q waves were considered a poor prognostic marker. It used to be thought that they represented infarcted tissue, which would mean non-viable, non-suitable for reperfusion strategies like PCI. But nowadays, with more and more PCI, we see that the tissue can be reperfused, and in some cases the Q waves can resolve, but not always. So what are Q waves? When you have damaged myocardium, you can have a reduction in the degree of depolarization running through that damaged tissue. It becomes electrically silent. A lead looking directly at the site of damage will see a negative deflection, a Q wave, which is an initial negative deflection. And this Q wave will correspond to looking through the damaged electrically silent myocardium to the healthy myocardium on the opposite side. Abnormal Q waves, or otherwise known as pathological Q waves, are identified by being present in leads where you would not normally expect a Q wave. So what I'm saying is a lead with a predominant, or where we expect a predominant R wave. Usually they're defined by being greater than 30 milliseconds in duration and at least 1 millimeter deep, or one small box deep. But let's look at some examples. So here's some pathological Q waves in the anterior leads. You can notice the small initial deflections in leads with a predominant R wave. You also have T wave inversions and some ST elevation in V5 and V6. And now here's another example in the inferior leads. Again, we can see these initial Q wave, these negative deflections in leads where we expect a predominant R wave. And this pattern could mean that the patient is having an MI right now, or alternatively, it could mean that they have had an MI in the past, so maybe a few years ago, for example.